Well, welcome to the CTSNet Roundtable on hypertrophic obstructive cardiomyopathy. The goal of this roundtable is to go over the teaching, organizational aspects, and research on HOCM, and talking with some experts who've developed their own programs in HOCM surgery. And I'll let my co-moderator, Carlos Mestres, introduce our panelists.
Hello, everybody. First of all, I'd like to thank the guests that we have today to kindly participate in this roundtable discussion about this special issue on hypertrophic cardiomyopathy, which is, as we all should agree, still a hot topic in a somewhat neglected disease with a high complexity. First of all, I'd like to introduce to you Dr. Cristina Ibanez. She's a consultant anesthesiologist at the University of Barcelona School of Medicine Teaching Hospital, the Hospital Clínico, and then she's running the hypertrophic cardiomyopathy program there. So welcome, Cristina. And then we have Dr. Pietro Bayona. He is the director of the hypertrophic cardiomyopathy program and director of cardiac surgery at the Forbes Hospital, the Allegheny Health Network in Pittsburgh, Pennsylvania, and also is one of the leads of the European Board of Cardiothoracic Surgeons Level 1 examination. So welcome, Pietro, and thanks for joining. And finally, it's also my pleasure to introduce to you to Dr. Juan Grau. Juan Grau is the director of cardiac surgery at the Valley Hospital, the Valley Health System in Ridgewood, New Jersey, United States. And he's also professor of surgery at the University of Ottawa in in Canada, and also the co-chair of a research scholarship committee of the American Association of Thoracic Surgery, and the chair of the Basic Science Task Force of the European Association of Cardiothoracic Surgery. So I think, and we discussed that before, that by having with us surgeons, and in this case an anesthesiologist, they will be a very important part of this integrated special issue, in which we have, of course, the cooperation of the cardiologist. And Dr. Maron from Boston was kind enough to record a superb video on the vision of the cardiologist regarding this complex topic of hypertrophic cardiomyopathy. And then without further delay, we have just a handful of simple but very important questions that we would like our guests to address today. First thing is no doubt why we are here, and probably an important question, which is the to look for the rationale behind a specific approach for hypertrophic cardiomyopathy and its surgical treatment. So we know that there is prior experience with different groups in other pathologies and diseases, like, for instance, the infective endocarditis, the heart teams, the cancer boards distributed all over the world for many years. So then the first question would be how to raise awareness and how to educate the community about hypertrophic cardiomyopathy. So in fact, the question is how to raise awareness on the disease, possible therapeutic options, surgery, and then how to educate patients and physicians, from the general practitioners to the cardiologists, anesthesiologists, and surgeons. So then, Pietro, if you would like to start just by saying some words and trying to answer this first question of today.
Well, thank you everyone for having me here, and it's a pleasure to have you to be introduced by a friend and a great colleague, as Carlos. To answer the question about how to increase awareness, I would reply with a very simple sentence. It's a daily work. Basically, you have to take it as your mission, if you like. If you have passion and if you want to focus your career on HCM, you have to take it as your daily work. And not only in your main hospital, you talk to your colleagues, to your cardiologists, to your anesthesiologists, to your colleague surgeons, EP doctors, but also in the community. It's very important, and it's actually, I think it's capital that you actually talk to your community cardiologists and also referring physicians and family physicians, because at the end, they are the one who are actually referring patients to the HCM centers. So that's my short answer to this.
Dr. Grau, you have experience in establishing programs you've done before. And then not so long ago, I think less than a couple of years ago, you moved to another country, another region, of course, specific characteristics. How then you envision this awareness? What can we do to raise awareness and educate the community? And how's your experience now in New Jersey?
Thank you, Carlos. Thank you for inviting me first. It's a pleasure to be here with you and all the other panelists, and a privilege. I've started 2 programs, one in Canada, one in the United States, as you mentioned. And my answer to that question, this is a diagnostic challenge, in my opinion. Most of these patients have something wrong with them. They don't feel well. They cannot do the regular activities that another person their age would be able to do. And the diagnosis sometimes, and in many situations, is unclear. And I think that stems from, as Pietro was mentioning, from the primary care physician all the way up to the cardiologist and the imagers. And so my job has been, I remember when I created a program in Ottawa, I won't mention the name, but somebody said to me, we don't have this pathology here. And I said, well, you don't have it because you don't have a program. I mean, if you don't have a program, you're going to see these patients because they're going to find that their way somewhere else to be taken care of. So the first blocks of the building that I've created have always been diagnostic. I have always been in collaboration with cardiologists to be able to identify what the problem is, especially for the obstructive. I mean, I have to emphasize 75% of the hypertrophs that we're going to be managing as surgeons are obstructive in nature. So we won't see the 25% that the cardiologists do see. They have other issues, arrhythmias and so on and so forth, but don't require our services. So we are already biased and by the fact that we see obstructive cases. Even within that population, which you would think is very easy to identify, many times that obstruction is not identified well because it's dynamic in nature, and the static testing does not show it to you or the patient or the primary care physician. So again, the building block starts with, for me, has been always echo, a stressed echo, CNS CT and MRI, and then prove to the patients and to their referring physicians that the patients are actually not crazy. They are not making up the symptoms. The symptoms have a very clear etiology, and is an obstruction, whether it's arrest or dynamic. That it doesn't matter. If you read the guidelines, it doesn't matter whether that is at rest or dynamic. You're able to identify it, and if you don't identify it, then you can say that the patient doesn't have this condition. But until then, in my book, the patient has that condition until proven otherwise.
Thank you. I think this is a very interesting comment, because raising awareness in the community is usually not easy, not only for this specific disease we are dealing with today. But when it comes to a bit of a more progressive kind of conduct, and we are now talking about the operating room, Dr. Ibanez, Cristina, how can you see the hypertrophic cardiomyopathy from the point of view of the one who's going to take care of the patient before the operation and during the operation, and in many other places after the operation? So how the anesthesiology community in current times today has a look at this disease, and how can we discuss with anesthesiologists just to be aware or have a look at the disease in a different way? So are all those patients that they are going to go to the operating room different from regular pathologies that we are used for many years, like coronary artery surgery or valve repair or replacement and so on. How you have a look, and then how would you address your anesthesiology community to raise some more awareness on what the disease is and how you are going to deal with it?
Mm-hmm. So thank you. I would also like to thank you, the organization, for inviting me to this discussion today. It's an honor to be with all these important surgeons. Yes, it's a very unknown pathology in our setting in anesthesiology. I think cardiovascular anesthesiologists are more aware of this pathology thanks to our surgeons that are starting these programs. So what it's a challenge as well is to teach this pathology to anesthesiologists that are not in cardiac surgery, which is also an interesting topic to teach them, because they can deal with these patients in non-cardiac operations. In the cardiac surgery setting, for the anesthesiologist, we know the pathology if the surgeons are doing these operations in our hospital. If not, it's really an unknown pathology for us, and it's very complex. So I think that's the challenge. That when someone is starting this program, we have to have a dedicated team to this pathology. I think that's the important thing to do.
Thank you. Patrick, at the moment you are a General Secretary-elect of the European Association for Thoracic Surgery. So we know that some of the societies in recent years, let's say in the past 10, 15 years, have come up with specific recommendations, call it guidelines, call it the way you want. So then how is going to be our society approach today, considering that we have some guidelines that are out there for a while? Do we need to do something else, which is the target people that we need to reach with or without guidelines?
I think there are several levels for this. The first one is, as you said, our guidelines are relatively old, and we do have more recent data. And if we look at the practice from excellent centers, such as the ones where Dr. Grau, Dr. Bayona, and Dr. Ibanez are working, they go much further in their management of patients. They're looking at less symptomatic patients, and that's not currently advocated by guidelines. We're getting more data that seems to show that that's for the good of patients. But I think we do have some work to do in terms of recommendation. And the second part, which is a little bit the point of this guest editor series, is getting out the awareness of this disease and how to treat it. As you yourself, Carlos, have written in several editorials, this is a vastly undertreated disease. And we need to improve awareness about it, but also train surgeons and the whole heart team to understand that this is not such a complex disease to treat. Once you have an adequately trained team to take care of it. Now, of course, these guest editor series help to raise awareness. But I think that this is something that should be more concerted by our associations to help teams. Within EACTS, we have Francis Fontaine Fellowship Funds. Maybe this is something that we could consider to train the future generations of surgeons in this type of surgery and developing these programs.
Thank you. Then I think we have more or less an idea how we need to work, and which is our final target for this type of disease. So then my next question, and I think it's important for the dummy like me, I'm very sure that our guests today, they're going to address that in the right way, which is how then to organize a hypertrophic cardiomyopathy team in a general hospital or a university teaching hospital at the tertiary care level. So which then should the basic requirements be? or how's the of course, the preoperative and intraoperative assessment, of course, with specific focus mainly on obstructive forms. So how can you address this issue of how we organize a team, or how you did it in your respective institutions, Pietro?
Well, very simply, first of all, you need what we call a champion, someone who is dedicated and who has a goal in his or her career, HCM, the HCM disease. This could be, generally speaking, is usually is a cardiologist, could be a general cardiologist or a heart failure cardiologist. Sometimes in some centers is interventional cardiologist, like it was in my previous experience in Dallas in UT Southwestern. And in my personal case is a surgeon, and I'm sure it's the same case for Dr. Grau. Once you have someone who's really dedicated, then this person, with the help of the administration of the hospital or the university, then starts to individualize the key team members. And one thing that I personally think is very important is to build a partnership with either a cardiologist in case you are a surgeon, or a surgeon in case you are a cardiologist, and basically creates a core team that starts to expand. So first is surgery, heart failure, or general cardiology. Then you need interventional cardiology, EP. These are the key team player, imaging, and with MRI and echocardiogram, anesthesia for OR. These are all the key team member of the HCM team in our center, or in any HCM center of excellence. Once you have this team built with people who share your same passion and you share your same interests, then you start what we said before, increasing about talking, giving talks, and going out for dinner, and increasing the knowledge in the community and in the city where you are about the existence of the HCM center. And once that takes place, then you'll start to see the more referrals. It takes a good year before you create a team, and at least 3 years before you start to see the results. So the beginning can be very frustrating.
I could imagine. So Juan, what do you recommend to organize a team for this type of disease?
Yeah, I mean, I am, the way I look at this condition, and you mentioned it, and I think Patrick also alluded to it, I take this as an orphan, then it's a family, right? So it's an orphan condition that has no family, no parents, no siblings, nobody. And when you come to a new institution, you have to create that family. And Pietro put it out very, very well. I'm very inclusive in creating that family. I don't think anybody should be outside the possibility of contributing to that HCM program. Obviously, you have critical elements, right? You have, and I would divide that into 3 spaces: the preoperative screening phase, the intraoperative management that Christina alluded to, and the postoperative analysis of your results, which I think are crucial, especially if you read the last guidelines, which are based on outcomes and not volume anymore. So when I do that, it's funny to me how in Canada, things, because it was a different system, the cases were already channeled from within cardiology to the champion, quote unquote, that Pietro mentioned, of HCM in the cardiology division, and then they arrived to me. That was a much easier of a job for me than it is in the United States, where I receive patients from themselves. They're self-referred. They don't feel well, and they know that potentially there's something that could be done. I also get patients from internal medicine specialists and primary care physicians. And then I receive patients from electrophysiology, from general cardiology, and from interventional cardiology. The TAVR program, for instance, which I'm a member of as well, provided 3 or 4 cases lately. The intraoperative, kind of family is as important, if not more important, because that, in my opinion, and I think Pietro will agree, is the quality metric of your program. I mean, again, you're the surgeon, you're going to be relieving an obstruction, and that relief of that obstruction needs to be objectively documented. If you don't have that documentation, for instance, if you don't do provocative maneuvers in the operating room prior and after the procedure, if you don't document the presence or absence of mitral insufficiency, the absence of presence of systolic anterior motion, the mitral valve, and so on, then you're not going to have a good quality metric. And so when these patients come out, you could have some, residual that you didn't do it, and if you didn't provoke them, you don't know if the patient is going to have dynamic MR. And then finally, the post-operative family is the family that helps the patient. These people are not going to go back to normal. Many of them are very obese. Many of them have not exercised for 2 or 3 decades. They don't know how to exercise. They don't know how to rehabilitate themselves. They don't know how to be a normal person because they have not been for so long. And so the team of nurse practitioners that I've put together here in the States do that for me. We have an exercise physiologist that help them exercise and learn how to exercise slowly and progressively after the procedure. And so I think that's basically the way I think you can get a successful program, is treating this as a child that has no parents, and there should be a family all throughout the steps that are preoperative, intraoperative, and postoperative for these patients to feel comfortable at your center.
Thank you, Cristina. So then how are you going to recruit your anesthesia colleagues for such a part of the team? So of course, it's clear that every institution may run the business in a different way. The departments of anesthesia, they may be different in terms of actual size, the number of people dedicated to cardiac anesthesia. In any case, I think that throughout the world, usually the Department of Anesthesia is one of the heaviest and the largest departments of any major institution. This is clear, and most of them, they may have more than 100 or 120 or 150 members across the board. So, but in terms of your cardiac anesthesia team at the moment, how did you recruit the people for the team? So how many people is working at the moment in this specific task? It's always the same people. Are you going to recruit younger members of the department, trainees? How are you going to organize your anesthesia team that's a part of the HOCM team in your institution?
I think that's a very interesting question for us. I think the first thing is you have to decide how qualified is your anesthesia team in cardiovascular surgery. And you need a high level of expertise, because you need a high level of expertise in TEE evaluation and a high level of expertise in cardiac surgery in general, because you will have to have this interpretation of images at the same time of have an understanding of what's happening in the hemodynamics. So first thing is to see if your team is homogeneous in knowledge. As you said, there are older people, younger people. That's the first thing. And the second one, that's to say if you can include everyone in the program. And the second thing is, we think that as for the surgeons, as Dr. Viana said, you have to designate one anesthesiologist that will be the link between the other anesthesiologist and the surgical team. So this person will be in charge of organizing the meetings, reviewing the literature, etc. And this person will be the first one to be trained from our point of view. And we will be trained in a sequential manner more than in a simultaneous manner. So one person is trained, and when this person is expert enough, he can teach the other ones in a sequential manner. This may take a lot of time, depending on the number of cases of each center. But for us, as anesthesiologists, for example, we are 8. The nice final picture for us is that everyone is able to do it. That may take some time, but it's easier for us. It's more motivating for all the team, and it's easier for our organization. So it's difficult to say, Cristina will be in the operating room this day and not another day. So the final picture should be that if you have a high level expertise team in anesthesia, I think with some time and a high volume center, you can teach all your colleagues. I think it's possible, but you have to do it in a sequential manner, not everybody at the same time.
I think this is.
I'm not sure if it was clear for everyone.
No, I think it looks.
That's an excellent point.
Yeah, absolutely. It's a wise approach to that, the sequential involvement of team members there. So then, how you do it at the moment, which is your pre-operative and intraoperative assessment of those patients coming many times in severe condition because of course, physical limitation symptoms or frank over the heart failure. How are you going to prepare them and run this anesthesia for these patients at the moment? What are your basic 2 or 3 key points, bullet points for us?
In the preparative period, we are not doing so many things. We have a rehabilitation program, but these patients are not included because they have a high risk of complications if they exercise, etc. So they are not included in the rehabilitation program, and they go directly to the operating room. So we are not too much involved in this preparative selection of patients.
Mm-hmm.
I would like to discuss maybe a point of improvement in our team is that we could discuss the cases one by one before going to the operating room to have a tailored approach. I think that's one of our points of improvement in the next months, to review the cases with the surgeon, so that we have also a very tailored plan or approach for each patient in the anesthesia talking. I think that would be a point of improvement for us, for example.
Yeah. So then for the surgeons, how would you, of course, again, this is a changing scenario across the board, but how would you address your patient follow-up when they are discharged home? Because as we know, one of the problems we may eventually have is that we may lose track of the patients of the follow-up. And then this is a substantial piece of information that we need to gather. This is known for decades in surgery. So I think that the value of what we do on patients or any other type of intervention is that to collect information over the follow-up, because then we understand, we know if what we do is truly good for our patients. And then we know that in the case of hypertrophic cardiomyopathy, this I would not say, but it's almost a curative operation. How would you address that in your departments, Pietro and Juan?
The way we do it at Allegheny Health Network is we run the clinic exactly as they were heart failure patients, like post-heart transplant. So there is an early, of course, follow-up, which is mainly surgical. So after their discharge, we do 1 week phone call usually, or if needed, they come to clinic. And then we do 1 month follow-up visit with me, with the surgeon, and where we do an echocardiogram and all the EKGs, and we have an echocardiogram that we consider that as a baseline post surgical myectomy. After that, they are followed by the heart failure cardiologist of the HCM team, and usually it's a 3 months, 6 months, and a year, and after that every year with echocardiogram or sooner if needed. The thing that it's very important, and I think it's we do, and I'm sure Dr. Grau does the same, is that we have meetings with the whole extended HCM team every month, where we discuss all the patients. Of course, if there is anything that needs to be said, surgical, medical, or post-ablations. And then every week on Monday morning, we have usually is a phone call meeting with the core team of the HCM, where we discuss the week ahead. We discuss the HCM clinic that usually is on Tuesday, and which patient we're gonna have, at what time, what to expect, the surgeries for that week. And so we already have a plan for the week. I wanna add a comment about what Christina raised. I think it's very important to discuss and include the anesthesiologist in the preoperative phase. I think it makes the life in the OR of the surgeon much easier to have a plan before you go to the OR, and that's why imaging in these patients, especially MRI and echocardiogram, is capital. Because in my short experience, I learned that not a single patient that needs myectomy is the same. You might want to do 100 or 200 myectomies, but every patient, when we go in, it's there's always something a little bit different. And every myectomy I personally do, I learn something new.
Yeah, so I think it's a question of ownership. I mean, if you want to open this program, you basically own these patients for the rest of your life and their lives. And so it is not like an aortic valve replacement that you can, send back to cardiology to follow up. Pietro has a very good setup with heart failure. I mean, we are doing it in the division of cardiac surgery, and we follow these patients. Obviously, normally we see them at a week, and then 3 weeks, 6 weeks, and then we do. I normally wait about the year mark. I do a stress echo, and then I do MRIs as well. And I'll tell you why in a moment to see how they are doing, and there's a reason for that. So it's complete ownership of the patient population. Otherwise, you just don't know really how well your operations. And again, what Peter is saying is very, very important. The operations are bespoke to the patient. I have not done one operation identical to another in anybody. Everybody has something different. One guy has 7 abnormal chordae, another guy has 1, but then that one is by releasing that one, you still have primary chordae that are too short. Then the septum is 30 millimeters, another one is 20 millimeters, and then knowing this heterogeneity that occurs in this population, you need to understand one thing, and is the most important thing you need to know is when not to operate. Trust me. If you go to a patient that requires a, basically debulking, as I call it, of the whole ventricle, you're going to kill somebody. And this can be only done, in my opinion, to probably the Mayo Clinic or, surgeons that are very comfortable in doing very complex hypertrophs with the distribution of the hypertrophy that is very apical. So those, and they barely have a cavity, right? So those patients are not going to do very well. And those patients should be identified in your program, especially a program like mine, which is now, new. It's the first year. It's not even the first year. It's a few months, and it's growing. You need to identify what not to do. So in terms of involving anesthesia, and Justina was mentioning this, and Pietro as well, it is crucial because they're going to see these patients in the operating room, and I know the anesthesiologists, they don't like to be surprised by what is this. I mean, this is very complex, and it's not fair to them for them to have to resolve this puzzle in 30 minutes or 40 minutes that it takes them to do, after they put the lines, they put them to sleep, and they do the echo. So the ownership of the patient should be absolute during the follow-up, and the inclusion of every member of the operative team has to be early, and it has to be very involved. So in my department of anesthesia, I have picked, because I'm the very beginning of it, one anesthesiologist that is very gifted with transesophageal echo, and that person has gone to Canada to see exactly how we were doing it there, to use exactly the same protocol. So uniformity, in my opinion, is crucial for a successful, for having good results. By the way, in terms of the follow-up, one thing I wanted to say, you learn that the LV mass regression can be as much as 20 and 30%, 3 or 4 years down the road. And for a 20-something-year-old kid, when you operate on them, that is a huge change. It's a complete different heart. At the beginning, when you did your myectomy with a 27-millimeter septum, to 3 or 4 years down the road, when that ventricle has a complete different anatomy, with no obstruction whatsoever, and with a LV mass regression in the 20% range.
Thank you. Just before moving to the next question that we have prepared for you, let me collect your input on a very important topic today, which is how can we actually involve more in the patients. Actually, a couple of days ago, the Asian Cardiovascular and Thoracic Annals has published an issue on hypertrophic cardiomyopathy, which it is available online now. And there was probably an important part of that, which was and is the patient involvement, the patient cooperation. Actually, you know that the Hypertrophic Cardiomyopathy Association in the United States was established years ago. So how can we incorporate the patient and of course sometimes the relative in this team puzzle? How would you recommend to do it? Because I think this is of course gaining more and more power in current times at the decision-making level. Juan.
This we did actually many years ago in the dissection group. I find it like a very similar pathology in a way that once you have a dissection, right, you own it for the rest of your life. And, you know, even if you fix, you know, and if you do even if you do whatever you want to do, the patient has had a dissection and the patient needs to be followed for the rest of their lives. And there's an element of stress and anxiety that is built into every single patient that has had a dissection repair. So I'm doing the same thing with my hypertroph cases, right? I try to explain the genetics of things in a way that is understandable. I try to include the relatives that are part of their family with tranquility, right? Because if you have 4 brothers and sisters and they're all 30-something years old, you know, you don't want to be, you know, labeling everybody as having one pathology that is phenotypically diagnosed. The genetics of hypertrophic cardiomyopathy is not universal. In other words, is not people that have. First of all, we don't even know what the genes are and how many actually matter or don't matter. So the patients want to be part of this, in my opinion. The patients want to understand more about this. These associations that have been developed in the United States is probably the oldest, are helpful, very helpful to the patients. And if you ask, I'm sure Pietro will agree, 2 or 3 patients that you have operate on, whether they would like to create maybe a local chapter of an association for them to start, you know, creating awareness, everybody's going to say yes, in my opinion, because they're so grateful, you know, that this was diagnosed in the first place and eventually treated.
Yeah, I think it's more or less like the example of Marfan patients, and there are
Correct.
associations in different countries, like in Switzerland. And so
Correct.
On. So, Pietro, quick comment on that.
Yeah,
please.
no, I agree with what Juan said, and I would say I would divide the patient population into subgroups. Usually, there is the patients who is very well informed already, knows everything about HCM, knows everything about myectomy, ablation, and they read online, saw videos, they talked to HCMA here in the States, which, as we mentioned, is at the oldest, probably patient awareness society. And then there are patients who are newly diagnosed, but they are dealing with this problem for many, many, many years. And maybe they're misdiagnosed. Most of the time is misdiagnosed with asthma or mismanaged. So it takes probably 2 or 3 clinic visits to actually talk to the patient and increase their knowledge. And I always encourage the patient I give them material, I give them publications, I give them video to make them more familiar with the pathology and everything that surrounds this disease.
Thank you. So, Patrick, we still have a couple of questions ahead of us in the next few minutes. Have any additional comment to what Juan and Pietro from the US have said regarding this kind of patient involvement or empowerment? You can use the word you want in any language. That's probably the truth.
Oh, I think they summarized the issues very well. And that we have to have patients involved. They're going to be living with this disease for their whole life, and the more involvement they have, the more they can take handle of it. We need to follow them up. We need to have them involved, and I think also in our trials we have to have more patient-reported outcomes, which seem to be increasingly popular, because we're not just looking at hard outcomes. We're also looking at improving their life and what our patients want. So definitely we need to include them in all of these. Maybe we should move forwards in our questions. Sure. Now that we have the team, we have our champion, the whole family around it. how are you going to start conducting the operation? What you have to plan for in terms of instrumentation materials, specific setups for intraoperative provocation. Maybe on this last point, Dr. Ibanez, what would you recommend putting together other than the team?
Yeah, I think you have to have a good TE machine, so that give you quality images. As I said before, of course, a high expertise team in TO, that we have talked about that already. I think one interesting point for us is that we have the possibility of have a cardiologist online almost all day. So if you have at the beginning any doubts, he can see the images from the echo lab, the images that you are doing in the operating room. So that's also very interesting at the beginning, especially in the post-resection assessment. If you have any doubts at the beginning, that might be very useful. And we also think it's important to have a storage image system, so that after you can review the images afterwards and look for areas of improvement, or use these images, for example, for teaching. So I think that would be the interesting elements to think about when you're starting the program. A backup, just in case, recording images, and a good TE machine. That would be interesting for us.
Okay, thank you very much. And Dr. Grau, what would you put into your surgical armamentarium to help you start your program and start operating?
Yeah, that's an excellent question. As you mentioned it, I've had the privilege to start programs abroad, and I flew with my instruments. So the instruments are very important, right? If you cannot reach something that you need to reach, you're not going to resect that's something that you want to resect. So, you know, I was very privileged because I was trained by Nick Esmedera, and so he basically gave me the list of all the things. Actually, some of the instruments that I use are manufactured at the Cleveland Clinic, and I had the ability to purchase them and then being sent to our center here. So that is a crucial thing. You know, you need to have all the things you may need at the time of the surgery readily available, because this is not an operation that calls for independent thinking or creativity. You should replicate what other people that are much more experienced than you have done, and what you feel comfortable in doing. So that's the first thing. With regards to the instruments in the armamentarium, if you will. Part of the armamentarium, which is crucial, is you know, colleagues like Christina. If they are not willing, and this is when I've flown, you know, abroad to open other programs, the reluctancy to really make these patients very sick in the operating room, to really see the pathology, and then repeat that. I use myself isoproterenol and orthobutamine and nitroglycerin, so I provoke them in the worst possible situation, raising heart rate to 140, 150 beats per minute, and dropping the pressure to like 80 or 90 millimeters of mercury. If you don't have a gradient with those conditions, as an outpatient, this patient is never going to see a gradient or MR or SAM or whatever it is that could be the residual result of an incomplete operation. So my advice to people is provocation is your friend, because you may have to reclamp, you may have to redo something. But what you don't want to hear is when the wires are already in and the patient is about to be discharged, that your post-op echo shows, you know, with Valsalva, a grading of 43 or 47. That's the last thing you want to hear, because you're already outside the operating room. The patient feels happy that everything has been done correctly. And now you are between a rock and a hard place, because those are not these ingredients to send someone home with from the operating room. So that's the two things that I will say. Once you have the patients, once you have screened these patients and diagnostically you're sure that you're going to help them, you have to have the instruments to help them with, and you have to have the aggressiveness in the operating room to make sure that when you're done, you are absolutely done, that there's no residual lesions that you need to address.
Thank you, Juan. Pietro, any comments on?
Yeah, no,
I
I agree with with Christina and Juan comments. I would like to stress 3 points. The operation for a surgeon starts in your training. I think it's capital that for everyone out there who's interested or has an interest in HCM, it needs to get to a place where they do this routinely every day. As Juan, I was very privileged to be trained at the University of Toronto with Dr. Ralph Edwards, who's a very established myectomy surgeon, and at Mayo Clinic with Dr. Halzer Schaff. So this is capital. That I think the operation starts there. You build your interest and you build starting to think about the operation back then. Then, as we mentioned earlier, the second point that I would like to stress is the planning before the patient goes in the OR. So check, discuss, double check, rediscuss the imaging of the patient with the patient and the rest of your team. That's very important. And then once you get in the OR, always, at least from my point of view, I always make sure that all the people in the OR know exactly what your plan is and what you're doing, from a perfusionist, scrub nurse, anesthesia, and the discussion between the anesthesiologist who's doing the TEE. Some centers have a cardiologist, but most of the time is the anesthesiologist, is a continued discussion, not only the beginning of the operation before the incision happens, but also during the operation and after the operation. These are 3 capital points for anyone out there who wants to, any surgeon who wants to start an HCM program.
Thank you. I think it gives us an overview of what we might need, which is not only strictly how to go through the specific surgical details, because I think the video collection, this guest editor series, is going to be extremely useful for the people, because as usual, an image is worth 1,000 words. So I think this is to discuss this very important points from the general perspective. So then the next question, then we are going to go through the final aspects of our discussion is about teaching and research. So we have basically a couple of very simple things: how to teach and what to teach. This is from the practical point of view. And then are we going to run which type of studies, clinical studies, basic research? How can we do it in surgery and in anesthesia, Juan? So how to teach, what to teach, and which is your proposal for the future in terms of clinical basic research in the surgical part of hypertrophic cardiomyopathy?
I think that's the mother of all questions, right? And when you look at the number of the population of European Union, Canada, and the United States is about 1.2 billion people. If you count, there is no more than 10 centers, maybe 15, that serve this population of 1.2 million people. I gave a lecture about this, and I know these numbers. So each center will be serving 121 million people. This is a completely unreasonable ratio, right? It is really not possible to continue. So you'll have to teach this operation to the new generations. I think that before you go into the how to teach, I will first answer what to teach. And what to teach is what Pietro was mentioning. You go in there, I have divided every operation because I'm not that smart, so I divide everything in stages. So I do the myectomy first, then I look at the mitral valve in every patient, and I look at the papillary muscles in every patient. So it's not that I'm going to intervene at all 3 levels, but that is my attitude, my discipline through the operation. I've staged this in a 3-stage operation, so I don't miss anything. I don't miss a papillary muscle that is abnormal. I just try not to miss anything. So the what is, when you have a trainee with you, is show him the data and say, what is it that you would like to do? Right? What are you going to do for this person? And I think that's the first answer that your trainee has to give you. To give you. If that person is unable to give you a coherent answer to this after he has shown curiosity and has been involved in HOCM, then there's not that much curiosity. There's not that much involvement. I mean, so the trainees that I've been able to train are people that understood. Like say, okay, this is what I would do. Whether they're able to do it or not, that's a different ballgame. I'm not talking about that. I'm talking about the what. They know what to do. Then when I let them do, when I was in academic centers, I always do something that is safe, right? So I do the first part of the resection. If you go towards the left of the septum, it was very difficult for you to cause a major problem. So you let them do that part, right? Then you identify the secondary chord, the ectopic chord that may be abnormal. You let them cut one or two of them. So it's like a very stepwise approach, and very it's a very painful training actually for this, because I think Pietro will agree. It's not, in my opinion, it's not an easy operation. That's why it's not done by a lot of people, because when you make a mistake, it's a big one. It's a VSD, it's a interventricular septal dissection, it's a pacemaker, it's a you have screwed up something, the mitral valve, something or other, right? So I think the what is the most important answer to the question. The how is a very slow, stepwise manner. I think if somebody is really truly interested, and you do, let's say, 50 myectomies a year, that person should go to either Cleveland or Mayo or Toronto, and go to a center where they do 200-300 a year and really get his or her feet wet with this pathology. If that is the level of interest. We sent a fellow of ours to Cleveland for that particular purpose, and she probably did at Cleveland, I don't know, 200 and something of these myectomies. So that is a number that gives you, right, the experience enough to understand a little bit of this pathology. Otherwise, doing it in a low number center is not really very helpful.
Thank you. So Pietro, quickly, what and how at your place?
I virtually agree with every single comment that Juan did. If you let me, I would add who to teach, which I think is very, at least here in the United States, we're having a very worrisome shortage of trainees interested in this operation. I was talking to some colleagues earlier this year, and honestly, there's very few surgeons who are trainee surgeons who are interested. From our point, what we can do is try to involve the trainees, try to explain, but it's a very high stake operation. And as Juan said, when you do a mistake, it's a big mistake. So I think that's, if you allow me, scares the trainees out of this operation. And that's a big problem, because despite the recent renewal interest in medical therapy for HCM with the new arising medications, I think this operation is here to stay. And actually, with an increasing awareness of this operation and better diagnosis, I think the surgical numbers will increase.
Finally,
so, go ahead.
Yeah, please go ahead.
No,
Sorry,
go.
No, I mean,
I was done.
I think that's of course a very good overview from both sides of the surgical input here. So I think it's clear that it goes more or less around what we have discussed up to now today, which is awareness and education at the community level, and then going specifically to the team. And I think this is a very important part of the whole business. So then finally, Christina, in anesthesia, so what to teach and how to teach. So I mean, that is going to be more on the imaging side, because you need to be a very good transesophageal echo operator, or is more going to be on pharmacology for provocation and assessment. So what and how are you going to teach your trainees, for instance, at the University of Barcelona?
I think teaching in anesthesia is easier than in surgery, because there are less risks. It's obvious. So I think what to teach is basic knowledge of the pathology, because as I said before at the beginning, in the anesthesia community, sometimes it's not a very known pathology. So that's the first thing. Interpretation of preparative tests, that's also interesting. So how to read an CMR, for example, or that should be interesting for the preparative discussion. And then T, of course, as we mentioned several times today, and hemodynamic management. And you have to know how to do a provocation maneuver. So to whom, at what moment, and with which, how are you going to do it? For example, with the butamine or whatever you decide to use with your team. That are, from my point of view, key points, learning key points. And then how to do it, I think storing images, again, for us, it's something that's very important. Being able to store images and having good recording. So being very systematic in taking the good images and storing all these images in the interpretive, because we can use these images to teach, echo images to teach our colleagues. And I think something that it's not very developed in anesthesia, and it's maybe more developed in surgery, is maybe exchanges with other centers. So go to other centers and see what they are doing, because we are a very large community, so we don't know each other sometimes because we're too many. So be in contact with other centers and try to, at the beginning and afterwards, just to see that we are all in the same page and that you are if you can learn other things, or to check if what you are doing is all right. So I think that would be what I would recommend, or what I would like to do.
Thank you, Patrick. Also quickly, CTSNet community is large. We know that for what cardiothoracic surgery is. So of course we can't compare to cardiologists, gynecologists, or massive communities all over the world. But the CTSNet has also played a role in this kind of orientation of research, because there are trials that they have been organized by CTSNet in the past. We have some examples in mind. So for that particular thing, because hypertrophic cardiomyopathy, as said by our guest, is in terms of the people who's actually dedicated actively to that, do you think that CTSNet community or the trials or studies can be organized from within the CTSNet community, incorporating different institutions, both sides of the Atlantic and beyond?
Absolutely, and I think this is a field where we need more recent data, better studies. We need to be organizing prospective randomized trials in less symptomatic patients, and see if we can improve their hard outcomes. And because this is already the practice in centers of excellence in HCM. So that's definitely something that we need to work on. We're already raising awareness through this guest editor series, but the CTSN Trials Network should definitely consider putting more energy into clinical trials in this field. Absolutely.
Yeah, thank you. So Dan, we go to the final question of this short questionnaire for our guests, and in the next 3 or 4 minutes, we need to address the issue of quality control, because of course this is exactly what we want. We want to deliver a good product for the benefit of our patients, and that this thing is going to last whenever possible forever. This is the point. So then how do you define high standard operative outcomes? And second, the outcome assessment, as it's been marginally said so far, is related to minimal volumes that are required for a program to be successful. Juan, can you summarize that in a few words?
Yeah, I think it comes, this is directly linked to the follow-up that you have with your patients. In other words, I have had to do recently a reoperation on a patient that probably looked okay at a week or 2 weeks after the operation, and eventually over the course of the first 2 years after the procedure, develop a recurrent obstruction. So provocation at the time of surgery is very important, because in my opinion avoids this problem, right? Because if you can come out of the operating room with what I call a dynamic obstruction that you have not been able to see because you didn't look for it, and then that is going to come back to hunt you down. So I think the quality metric of your program is directly related to what you're doing in the operating room and the follow-up. So when somebody, I learned I'm sure, I don't know if any of my cases have recurred, but I'm sure the surgeons that have reoperated, if any of my patients ever, learned from what I dictated that I did in the operating room and what I, thought was the right thing to do at that time. So without a very close follow-up, and that's why leaving this in the hands of our colleagues from cardiology is not good enough, because you need to understand what Christina was saying. Okay, well, if I look at the image in 2000, and I look at this echo now in 2003, this person has another, has a residual, has an obstruction. Was that obstruction hidden back in 2000 or not? And that's how you learn. And that's how you expand the aggressiveness of your operation. So without following your patients and doing, I stress everyone at a year mark. And if I have any questions, I'll stress them again. I just want to know, are you really asymptomatic, or is it that you're not doing enough to become symptomatic? So that to me is the key, is the follow-up and the aggressiveness of the follow-up that stems directly for how aggressive you were in the operating room in terms of provocation.
Pietro.
I would summarize with 2 points. The first point, definition of gold standard or high standard surgical results is what we learned from major centers. Mortality below 1%, very low LVOT gradients at rest and under stress, virtually very no VSD surgical, iatrogenic VSDs, very low rate of pacemaker insertion. These are the main, no intraoperative mortality, as I mentioned that. These are the main parameters that we use. For the rest, I would say a lot of self-critic, and as Juan mentioned earlier, ownership of the patients. It's very capital and very close follow-up, and that's there you have it.
Cristina, then to finalize, what's your quality assessment in anesthesia?
I think I will agree with Dr. Grau that one important thing is to be able to compare when a patient is not, because the surgeons are doing the follow-up. So what we have to provide them is that good images in the intraoperative assessment, so they can compare and see how was the patient at the end of the operation when the patient is not going well in the follow-up. So in this, it's the only way to look for areas of improvement, I think. But if we have recently reviewed, like I think the last 3 years cases, and we have realized, for example, that we were not systematic enough, that we were doing provocation maneuvers and we were not writing the doses, for example. And this is it is not good because we are doing it, but then if the material is not good, it's not helping the surgeons for the follow-up. So I think we have just have a meeting about this, just to be a little bit more careful with what we are doing and what we are recording. So this will help the surgeons in the follow-up if a patient is not doing well afterwards.
Thank you very much, Cristina. I have to say that from my side, I'm done. And I think the actual role of the moderator in any session is, first of all, not to distort much the guests and the audience, and number 2, to learn. And I think that today's session was, I think is close to reaching its goals, which is to understand which are the important parts in terms of our awareness, our education, our self-assessment, and of course to look after quality control, because the ultimate destination of what we do is our patients. This is very clear. And I think that in this particular topic of a complex disease, still unknown in many aspects and very difficult to perform, as our surgeons have confirmed, and our anesthesiologists too. I think that this is what we have learned today in this roundtable discussion. And I'd like personally to thank Cristina Bañez from Barcelona, Pedro Bayona from Pittsburgh, Pennsylvania, and Juan Grau from Ridgewood, New Jersey, their input tonight. So thanks very much. And then I'd like my senior co-moderator, Patrick Myers, again, the Secretary General-elect of the European Association of Cardiothoracic Surgery, an important part of the CTSNet community, to close for the benefit of the audience. Thank you very much to all.
Well, thank you very much to this expert panel for really giving us some excellent insights into how to raise awareness, develop a program, and learn the basic tools of how to learn these procedures, develop a program, also how to teach this, advance research, and make sure that we're getting the optimal outcomes in our patients. Carlos Mestres, thank you for being the maestro in this and leading this panel very well. And thank you very much all for your attention for this webinar.
Thank you very much.
Thank
Thank you
very
for
much.
having me.
A pleasure.
It's
Happy
been
for
an honor.
having you.
Thank you.
Thank you.